So I'm going to apologize because in my tradition, in my cultural tradition, I should have paid homage to my elders who are in the room, you know, my wisdom keepers who are in the room. And Dr. Wade Nobles is one of them. When I was a mere child in college, many moons ago, he was the instructor that spoke to my soul and enlightened me and caused me to shift my perspective on the direction that I was going in. And I am grateful, forever grateful to you, and just love being in the space and listening to every word you have to say. My heart goes, yes. So thank you so much, Baba. I appreciate that. The other wisdom keeper who's in the room is, I was getting ready to call her Reverend Elder Dr. Sandra Naylor Goodwin. She didn't get that. And she is the CEO of CiMH, and I'm going to allow her to have the first reflection.
Thanks, Doretha. So I'll start out by a confession. I'm a Westerner in the way I think. So listening to you all, or your panel that was up earlier, was not new to me for sure. I've heard these stories a lot, but it's still always, I have to find a way to cross over and think and feel the way people do from other cultures, which is not always easy to do. And I will say that, well, even though I'm a Westerner, I have a lot of Native American heritage. I've got Iroquois, Cherokee, and Choctaw in my system, but I never lived that life. I never lived a Native American life, so I don't know it in the same way. So as I think about it, I think about how critical the words of the wisdom keepers are, and trying to think about how do we support this? I mean, that's because I'm a practical person, so I think about how are we going to support this work? We are fortunate in that we have the Mental Health Services Act, which allows a fair amount of flexibility so that we can do some of this. But in the long haul, how can we support this kind of healing practices that are so important to different people? And I haven't figured that out. I know for sure Medicare and Medicaid are not going to pay for it. Oh, wait a minute. He says we do, so let's hear about that.
I didn't mean to jump in and take your word of wisdom. So I work for a health plan, and I think there's a misperception on what insurance would pay or not pay. Actually, if you think about Medi-Cal and Medicaid, all it needs is a licensed professional. And I have to apologize for those who are not licensed, but you are a practitioner. We live in a system that designated that way. So when I say licensed practitioner, I mean licensed psychologist, licensed family practitioner, marriage and family practitioner, and licensed social worker. It just said that you need a licensed practitioner and you need to be able to produce a CPT diagnostic code and a service code. It really doesn't dictate what service. And as I was listening to the panel up here, I thought, what a wonderful way if we could find those licensed practitioners that are trained in the Western world, but yet practice traditional healing practices, and we just engage them into providing the services. Because all, as a health plan, as an insurance provider, all have to do and have to show us that there is a licensed practitioner who provides the services. There is a clearly, lack of a better word, a DSM diagnostic code. And yet we're able to demonstrate the improvement. And Doretha and I were just talking, well, how do you show improvement? We show improvement when a client went into a session with Dr. Wade, came out, and vibrate differently and happy. That is the outcome. So, yes, there is a way. It's not true that there is no way to fund for it.
They're going to tag team each other. I need to pull the mic.
This is my last comment. I just want to say that we need somehow to convince our State Department of Healthcare Services that that's true.
Well, you know, we're always having to break new ground. We can try to figure that out, yes? Yes. I'm going to the back corner over here. Is there anyone over here who has a reaction that they want to share to the Wisdom Keepers presentation this morning? Anybody in this? If you do, stand up. Okay. I need to move around. I can't sit in one place for a long time, and so it's good for me to, so walking is great.
The beauty that I heard was the center is the same. In everyone who was talking, the center is the same. And the compassion for each other, the compassion for ourselves was the key for me. And I really appreciate that because that reawakened those thoughts in my mind that I'm going to take back to my practice and to the folks that I work with. So thank you.
Awesome. Okay, I'm coming to that section over there. Anybody over there, if you have a comment, I want you to stand. Great.
They bullied me to do this, so. I was very struck by the fact that what was really being cultivated was the healing of memory. I feel like the essence of what was saying is like there's memory that needs to be captivated and captured in a way that inspires from generations to generations. And I think there was a healing moment of memory that was happening in that space right there in front of us. I'm not sure if you guys experienced it. It was really about that. Right? It was a healing of memory, which is not just healing of the body, the mind, but it's also the memory and how we view our traditions and our cultures and those traditions that have been passed on to us. Another thought I had was with regards to this metaphor that was very beautiful with the 7 directions, right? You got the wisdom keepers on the elders on the north side, which is the direction, right? North is the way that guides. Once you orient to north, everything else can be oriented, right? And then you have the youth in the south, and then the east being the male, and then female on the west, and then the north, the sun, and the south. That was beautiful. And at the center is this coalescing piece where all converges at one point in time, where we experience reality as we understand it in this very moment. And thinking about the Cambodian, because I'm also working with the Cambodian ISM, and one thing that really struck me was the idea that when the Cambodian Revolution happened in 1975, in year 0 is what they declared it. And what had happened was there was a flipping of generations. So that all of a sudden, everything of the past, that's what Leon was saying, all the traditions, the music, the food, the religion, everything was gone, wiped out. So all of a sudden, the North was just straightly just gone. The direction of guidance was gone, lost. And all of a sudden, what emerged was those who were in power were the youth. They're the ones giving the guns, they were fighting the wars, they were the ones making the decisions who were living, who would die at the ground level. And all of a sudden, what had happened then when we came to immigrated to America, the same thing had happened. Who became the cultural brokers? It was the youth. They understand the language, they understood the cultural customs, and so the parents all of a sudden had no way of navigating without the help of the South. You get what I'm saying? And so at that point then, we had this imbalance where all of a sudden the power and the wisdom that was there all of a sudden had to rely completely on the South, which with the lack of guidance and understanding of tradition, they were just trying to figure out, where do I anchor my reality? Where do I anchor my sense of meaning and purpose and identity? And where do I draw healing from? And then all of a sudden, where we draw healing from is MTV, right? You know what I mean? And so I just thought that was very interesting. Thank you for the thoughts.
Make sure we have your card. I'm coming to this side of the room. Anybody over here want to share a reflection on this side? Okay, coming your way. All right, and then we're going to turn it over to our panelists.
Hi, my name is Susie, and I'm from LA Care too. I just want to share with you what I wrote to my dear brother and friend here. I wrote, these messages really speak health to me and touch me deeply. I feel my tears many times this morning.
Yes, beautiful. Thank you. So our panelists, Gigi Crowder, you want to start?
Thank you.
Go right ahead.
I've been very anxious and hoping we had enough time for us to share.
Is your mic on?
Well, I was told that it would be cut on. Can you hear me back there? Yeah. Okay. So we're coming from the county perspective, and I really resonate with Jerry and sharing with us walking into a room and not feeling wanted or safe. in the room. So I'm hoping this is a safe place, because if you know Gigi Crowder, you know I'm transparent, and you can follow me with a videotape. I'm going to be true to the way I feel about things. So my response to this morning is, woo, but we knew all of this. Those of us who work in the role of the ethnic services managers, and we're there to share wisdom with decision makers. If we're doing our jobs correctly, we have met with people like Dr. Nobles in our community. We've met with other cultural brokers for specific ethnic communities. Our job is then to carry that message back and to advocate for doing things in a manner that honors each. Mm-hmm. Many of us are wearing the green ribbons for Each Mind Matters. I'm very intentional about that, because I do think we need to be, in 2014, not approaching our work from a missionary approach, which has hurt people through the years, a one-size-fits-all, but I still see us using what we call evidence-based practices, things like mental health first aid. And for me, I looked at it and I said, great, we finally have a tool developed in Australia, but it's a tool, and it's going to inform the mass about mental health. But then I looked deeper, and I realized the most important thing that connects individuals to their purpose, which is what Dr. Noble spoke to, is what we live by, our purpose, getting connected to it. Most of us, when we get there, then we feel free to live in this world. What's missing? What's missing from mental health first aid?
The cultural aspect is
spirituality. So each of the individuals that were here, they spoke about the importance of being spiritual people. So I can't promote something that leaves one of the more core ingredients, yet we're all doing it. Mm-hmm. And so I said, okay, well, that's missing. I'll go back and I'll ask the developers, can we at least change the videos so that they're more representative of the diversity within our communities? And I was told no. So as long as we continue to promote things, and it swept the country, even has our President Barack Obama speaking to the great work through mental health first aid and education. I can't promote things like that. And I'm told not to talk about it when I share that it's missing a core thing. So for me, having individuals validate that I am doing this work from an assignment from God was very, so the tears did flow for me, because you shouldn't be working in this field if you're not passionate about supporting individuals to connect to their purpose to heal themselves.
awesome. Awesome. Thank you. Cuco?
Thank you. My name is Refugio Rodriguez. I work for Santa Barbara County. And it's a little bit hard, I think, we as a panelist, to follow the group that was here before us. And it's also very difficult to stay on script in terms of talking about some of the strategies that, for many of us who consider ourselves social activists or representatives of our own communities, working within these bureaucratic structures. I think that regardless, for especially most of the people in this room, and certainly the people here on the panel, when you work for the types of systems that we work in, and we employ the most basic strategy, which is to speak the truth. But along with that comes these additional burdens that I think everybody's very familiar with, which is that you get labeled as here's Cuco again, you're not the team player. The things that I think the panelists before us talked about, that you feel that resistance in the room the minute you walk in. These meetings that occur, they happen to forget to invite you because, again, you may raise certain issues. I point to these not because this is a kind of a cathartic process for me, although it is. It's helpful to throw this stuff on the floor and just leave it there. But more importantly, I think what it points to, it's this very perverse and unfortunate part of what exists in our institutions and in our systems. We are very good at identifying the individual transgressions, like the gentleman from the Clippers, those types of transgressions. We can identify those, and we all will agree. where what we don't like to do as a system and as a culture, as a community, as a whole, is identifying those institutional racist processes that exist. And I can tell you that working in some of these systems, as probably many of you know, those are the challenges that we face. To me, these parts of the parts of these discussions that we're having about, strategies. I mean, I try to speak as much as I can, and I tell people, this is my battle fatigue, a suit and tie. I don't like to wear this, but this is half the battle for me sometimes when I go into these meetings, because for some odd reason, being late will kill you in this profession, right? It's a Anglo thing, I think, or a professional thing. If you're late, you could be the best at whatever you do, but that will overshadow every aspect of your competence. The other part is being well dressed. For some reason, you can be the most incompetent person, but people think, oh wow, that was fabulous.
You're great.
Okay. So at minimum, to hide my lack of intelligence, I try to be there on time and wear a suit and tie when I need to when I go to a meeting. My point is that for many of us, when we're part of these systems, is we try to point out, and it's very tiring, that every meeting, and I think we've all struggled with this, is that these are people you work with, people you probably like, but inevitably at every meeting, it's you that has to point out gender issues, LGBTQ issues, Latino issues, African. In fact, the room will look at you as if, aren't you going to say something? Oh.
Go silent.
And my point is that it's very tiring, because you begin to even question your own sanity as a professional, saying, am I speaking Spanish? Am I not saying it appropriately in English? What is it that I'm doing where it's a repetitive thing? Other professionals don't get this level of disrespect on issues. And I think that what it has to do is the most insidious way that the level of discrimination and the level of lack of acknowledgement of where our reality begins. And to me, that's the very essential thing, is that we are always given a script that was originated in a different culture, that we have to, that's the draft, make the adjustments, but this is your starting point. What we need to continue to address is the fact that our point of origination, if we're going to be culturally congruent, sensitive, or whatever it is that we're using today, inclusive, I don't know, I mean, it's changed. I think it was tolerant for a while, I think that the point of origination for interventions and of a lot of these things needs to be from our own definition, from our own community, what we find value. How do you assess some of the things, and how do you put outcomes and data and all of these things on some of the things that the folks that were up here were talking about?
Yeah.
You can't. When I was young, my kids are here, and I always tell them a story about my aunt. When my aunt died, one of the most painful things for me was that she would no longer be praying for everybody. As a kid, I would see her with a rosary, and I'm saying, Tia, what are you doing? And she said, Mijo, I'm praying for your kids. And I'm going, I'm 13, I got no kids. I said, Mijo, I'm praying for your kids. I said, and every day, all day long, any free time that she had, she prayed. And growing up, I always felt that I had this extra protection.
Yeah.
Because my aunt, we call that resiliency, right? Yeah. How do you assess that? And again, the things that are valued to our own communities needs to be our starting point. When we look at evidence-based practices, they're not necessarily assessing how successful our communities are. I mean, there's a lot of evidence in terms of evidence-based practices and communities of colors in terms of their lack of effectiveness. In fact, there's more evidence of that than evidence of their effectiveness with our own communities, but we don't talk about that, okay? So I want to be clear about that. But secondly, that is an example of us buying into these very broad and very key ideas, and we sink everything into it, and we neglect the impact and the disproportionate effect that it has, or lack of evidence that it has, on communities of color. And again, to me, evidence-based practices are an example of that. They're also an example of not gauging how successful things are, interventions are with our own communities. It's really how successful we are in mirroring the success with white communities.
Right.
So for me, I think in terms, to try to get back to topic, I'm sorry. I think that a lot of the strategies that we really need to utilize, and will continue to utilize as some of us who work in these counties, is really to continue to speak to these things within our own systems. But more importantly, I think we need all of you to continue to support what we do as well. And again, remember that for many of us, because we do work in county systems, that does not mean that we're not advocates. I mean, in Santa Barbara, I work in Santa Barbara, there's a lot of social activism. And I remember after a couple of years of working for the county, a person that I knew for a very long time, he said, "Oh, Cuco, you sold out." And I'm like, oh my God, you know, because I work for the county. And that's what I want to remind people, that for many of us, we are advocating. And it's actually a tougher job to do it within the bureaucracies that we work with.
Yes. Thank you, Cuco. Dennis Murata, is yours working?
It's working. I just want to know, Gigi, what Cuco said.
No, go ahead.
Okay. Anyway, good morning. I'm Dennis Murata, LA County Mental Health. Coming in here, I thought, gee, why am I here? I'm a member of the executive committee at CiMH, and also something that we've supported big time in LA County was the use of evidence-based practices, and me personally supporting the use of mental health first aid. So I'm going to move over a little bit here. These are not perfect things, but I'm going for it because it's the only thing that we have at this point. And I believe me, we had an interesting conversation yesterday, and I was hoping that we can kind of repeat that dialogue.
Okay.
But you know what? It's not important to do that now. But anyway, so I've been, as of September, I would have spent 40 years in mental health, 30 years in CiMH, in the public mental health system. And I tell you, the issues that are going on now, they've been going on for over 40 years or more, at least from my involvement. There's a lot of work that we have to do, but I have to tell you, commenting and piggybacking on what Sandra said, thank goodness for MHSA, because a lot of this stuff wouldn't happen. Take a look at our system now. It's Medi-Cal driven. You have to meet medical necessity criteria. We have a distinction between specialty and non-specialty mental health. But one thing, and I'm sure other counties have done this too, is the involvement of stakeholders, the involvement of family members, consumers, parent advocates, folks from the community. That has driven our system in a positive direction. And I'm going to say this, and I hope I don't really piss off any of the clinicians in this room, but I'm sorry to say this, but I do believe it. EBPs and mental health is not the cure for every damn thing. You need community support. You need all these practices that were talked about today. I'm sorry, Clayton, we're not going to get a lot of ministers and healers who are going to be licensed professionals, but if we do, that would be a great day. But we have to build a system that's going to support people who need our services. But we are not the end-all and be-all. That's why it's important for us in LA County, as well as others. We're talking about healthy neighborhoods and communities and those type of things, where the community support, they don't have to be funded by mental health. You're looking at the neighborhood and at a community level, what are the types of things that are going to support individuals and their families? And when I say families, yes, thank goodness for many of our cultures, the importance of family is there, but there are people who have no family. So that's why it's important for them to develop other type of support networks as well. So the importance of peer support, self-help, even when individuals come to me, yeah, that's okay. Go see, get assessed by a mental health clinician, but I think in your situation, go and look at a self-help group. Go to a peer support group. Get your family involved in your recovery. All those things, or if not your family, get someone that's significant or develop those support networks. So you know, maybe this is something that I shouldn't say, but we need more than just EBPs. And even with dealing with the EBPs, yes, I hear it. I deal with it every day. They're not culturally relevant in many cases. Some of the developers, I hope there's not any developers in here, but you're talking about a bunch of divas and other folks who do not want to adapt their particular practice. But I also have to say, there are certain practices that are effective. But that's more the exception than the rule. But we have to develop our own. I think in California, in many of our communities, we've been struggling with this issue for decades. And a lot of the things that people have been practicing are very effective, but we don't meet the rigors of the evidence and the research and those type of things. But I'm afraid, looking at where the mental health system is going, that's the direction we're going. We're looking at outcomes. We're looking at performance measurements. We're looking at managing care. Well, my feeling is oftentimes care isn't managed, costs are managed, right? And you take a look at the folks who do not get into our systems. API is a very good example. And we've talked about this with other groups. In LA County, we have UREP, which is the Underrepresented Ethnic Populations Group. And it was formed exactly for this purpose, where people can advocate and support for their own ethnic communities, but we do it together, okay, as a force for ethnic minorities. Underrepresented, yeah, to some extent, but there's also overrepresentation. You take a look at LA County. Do you know what the largest mental health provider is for Latinos and African Americans, and believe it or not, Filipinos? It's our jail system. Something is wrong there, right? So you take a look at those different things, but you can't say, well, gee, did we fail because we didn't do enough talk therapy, maybe we didn't prescribe the right meds. No, this is a larger issue that we're gonna need the faith-based community, we're gonna need healers, we're gonna need support from everyone else to deal with this situation. And that's what we're trying to advocate. Now, you did pick the wrong person, because part of my responsibility has to do with QA and Medi-Cal certification. This ain't gonna happen, okay? Not in my lifetime, I don't think. However, okay, but there are other things you can do, all right? Because you figure the direction that we're going now with the whole certification, come on, many of you have been part of audits that are happening. They are looking at things very closely. These type of things, how we have to integrate them to make them effective. I don't know, and Sam, you tell me, with something like this, we can't even get outreach, which is needed, as well as translation services as part of something that, or even interpreter services as being something billable to Medi-Cal, right? So the system is what it is, so we have to work around it or work through it, right? So anyway, I'm sorry, I'm taking it much more time.
No, you're fine. You're fine. I just want to get ahead of Gigi, because I know Gigi's getting ready to come with it. And so what I want to do is integrate some other questions into the mix, and then, you know, so if you look at your watches, just go ahead and look at your watches, because I know some of you are already doing that. We are already into the breakout times, okay? And we're still, I mean, how many of you feel like this is something we should continue to go with? I'm just gonna kind of take a, okay, all right. So tell you what, why don't we take the liberty of another 15 minutes or so, and we're just gonna limit it to the panelists' reactions, and then we'll let you go to your breakouts, because we're already late. The schedule's shot, so you just might as well live with that. All right? Okay. I'm just having all kind of reactions here, because I work in an organization that promotes evidence-based practices. Our evidence-based practices team and our Center for Multicultural Development have gone to blows several times about, you know, the effectiveness of evidence-based practices, the utility of community-defined practices. That's why we're hosting things like this, because we want to have a conversation. And we do want to make the system transform. We want to make sure that something different is happening. And somebody's got to take responsibility for it. And the challenge in our world, those of us who sit at these tables, is that we have to, in some way, you know, maintain vision, hope, persistence, energy, encouragement. We need folks on the ground to be advocating and talking these things up and making sure that it's being promoted on the local level and that your legislators know about it and that they are aware and that there's energy created. I've seen miraculous things happen, when people come together and they all sort of push their energy through one hole, as opposed to multiple places. I think we can do that. And yes, it might be when you're no longer living, Dennis. But we may see it. My grandmother didn't get to see, an African American president, but my son has gotten to see one. And so, so we have to kind of see ourselves as the groundbreakers, the people who are digging the next trenches for, that next iteration of service delivery system that might be in formation right now as we speak, right? You were invited to sit here at the table because you are doing some innovative things in your counties. You are in some way trying to grapple with these issues and bring them into the fore. And they are complex issues. I mean, not only are they complex from the system versus the people kind of, the systems versus the people, it's also complex because the people themselves don't necessarily agree. And so, we've seen this in the community-defined the CRDPs, the California Reducing Disparities Projects, and all of these things. I mean, there's lots of conversations. Earlier, one of our speakers spoke about, lack of agreement between folks. There's lots of issues to be sort of worked through, and so we're gonna leave that complexity in the air and in some way try to have a conversation where we can begin to create bridges between some of these discussions. So I'm going to ask you, what have you and your agency done to integrate or support indigenous practices or community-defined practices or community-based practices into your system or service array? And you've already started talking about some of the barriers to integrating these practices. And what practices or strategies in particular have you used to sort of overcome these barriers?
Okay, I'll start.
Yes.
I can say in Alameda County there's been great improvement for Native American, Latino, Hispanic, and API communities because through the Mental Health Services Act, which was great that it got passed. I was out there with my twin sons getting signatures in 2003 to get it on the ballot. So I had great hope having worked in the field at that time for about, 15 years, because I started when I was 10. But for about 15 years, so I was very excited about and hopeful for what it would do to shift things and create more opportunities for underserved communities. But there was language missing about inappropriately served communities. So I'm 10 years out from the Mental Health Services Act, and I still haven't seen it truly address the needs of African Americans. For whatever reason, through full service partnerships, in my county in particular, we always were in high numbers in the most intensive services, but when it was time for housing and employment, somehow we couldn't find the African Americans. But you can always find them for other more restrictive environments, and that's where they continue to be, as you indicated. So yeah, you do have Latino and African American, and you're saying in this county Filipino, but throughout the state, the largest number by far is African American in the criminal justice mental health systems. That's costly, because when you're in the criminal justice mental health system, guess what? There's no Medi-Cal billing at all. That's the county's general fund. So from my lens, it's like, hey, guess what? I have an idea that using an upstream approach by looking at the root cause and starting addressing it practically, because for me, this is not complex. It's let those communities, give them the dollars, let them figure out how to do it. We did that for the other communities in prevention. So in the prevention now, if I get a call from someone from the Afghan community who's a family member who has a loved one, I can tell them to call the Hume Center or the Afghan Coalition and all of this. I still do not have a place in Alameda County that I can tell them that they can call specific to meeting the needs of African Americans, and that's true across the state. And for me, the Mental Health Services Act has failed that community in a big way when you do not have those services specific. You can have an executive director who's African American at a company that employs the most qualified individual, but if not specific services for that community, and if their cultural needs are not being met, your outcomes are going to continue to be the same. So for me, it's like, why are we wasting all of this money? Some of us have full service partnerships that allows an individual to get housing, employment, and all that. That's like $100,000. Give me those same 10 individuals with severe mental health challenges. Give me the $1 million, and then I'm going to be buying me a Bentley with the remainder of it, but they're going to be well taken care of. They're going to live well. They're going to eat well. They're not going to be re-hospitalized. So it's a waste because we're not doing it in a way that really meets the individuals where they're at a lot of times. And so what I do is I walk in and I say, I found a great program that's an upstream approach that resonates for individuals. It could be a hip-hop therapy program, and I'm excited about it because I think this will work. I've seen since these young people have been participating in this, they haven't gone back to juvenile hall. They have stayed in school. They've done this. And it only costs this amount of dollars. When stuff like that doesn't get funded, I have to start thinking about, is there a system in place that wants to keep things the same way they have been for certain groups of people? Because if this has been proven, now no, we didn't spend any research money on it because Rachel Guerrero, Janet King, all of my heroes have taught me that when communities get nickels, they know how to stretch them. They wouldn't be spending the money to prove that something works when they already know it works. So who's going to invest in something like that and waste the dollars when you can look in the face and see the need right there? I'm going to tell a young person in Oakland where we pick up the newspaper and hear about the killings of black-on-black crime, which was mentioned earlier. We know what that looks like now. That's suicide by proxy. I don't love me. Society doesn't love me. I'm looking and shooting someone who looks just like me. I'm going to tell them, I want to research. You hold on. I'm going to research if it'll work if I spend money on saving your life. Does it make sense?
Go ahead.
Well, you know, in Santa Barbara County, I want to respond to your question, but I think we also have to provide a little bit of context. And
Sure.
I don't want to be negative. You've heard my spiel on evidence-based practices. Despite that, we're actually investing in that in our county with the caveat that we're going to implement that across our counties with a particular focus on cultural adaptations. Now, it's an oxymoron. And the reason I say that is because the whole purpose of evidence-based practices is that you follow this predetermined blah, 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 and then you get success. And now we're saying we're going to adapt those. And at this point, because I'm also a realist, we're not turning back this train on evidence-based practices. Our profession has bought into this and completely ignored whether it's successful, where it works with our communities. That's not even up for discussion anymore. So the question now is, what can we salvage and can we adapt some of these, or at least prove that there's no way that they're going to work in our communities? So I think that's more of an institutional step that our county has taken. Under MHSA, which is, again, part of my role, one of the really big things that occurred in our county is that our threshold language, our only threshold language in Santa Barbara is Spanish. And I was able to argue that we need a certain percentage of bilingual, bicultural staff in any MHSA-funded program. So as far as I know, we're one of the few counties that has like a 40%, 50% requirement of bilingual staffing within any MHSA-funded program. When that first got proposed to our executive team in Santa Barbara, I said, something like 60%. And we argued down to 30, and I walked away, and they, thinking, wow, I didn't think I'd get anything. I got 30%, cool. Because my point was, give me a number, 2%, 5%, give me a number that we shoot for. Because what I heard continually was, there's not enough professionals, there's not enough people of color. Let's shoot for something. Let's commit to something as a system. Because for me, when you institutionalize a standard like that, it's very, very hard to walk out of that. And I've learned that from bureaucracies, is that if you institute good things into these, institutionalization of policies that are good for our community or moving us in a certain direction, then that's what we point to. Because without those, it's very hard. We're just individuals saying, I think, no, policy indicates that we have to do this. Over time, we build it up to about 40 or 50%. And I point to that because without any workforce capacity, it's irrelevant to invite the community to come in for services. Yep. And that speaks to, again, this broader issue we talked about previously, which is the assumption that we all are at the same place. We have moved forward with how we're going to approach this mental health issue in our country under the assumption that we all agree on what that is, under the assumption that we all have the same definition of mental health well-being, and we do not, under the assumption that stigma is the same in all communities, and it is not. In my community, if you say mental health, it does not mean anxiety, loco. Crazy. So to assume, oh, we have services, please come in. No, we have not engaged. If anything, what we have to overcome is a legacy that we have established with certain communities. So what we're attempting to do in our county is to develop those kind of connections with all these communities and repair either our lack of relationship or repair our relationships and kind of what has not worked in the past with the legacy of not only our department but other systems within our county as well.
Very powerful. Dennis?
So in LA County, actually piggybacking on your comments, like I said, we are very committed to evidence-based practices and those type of things. But also there's other things that we also need to do. We need to have a diverse workforce. So we've done things at various levels regarding licensed and waivered staff to make sure that when our stipend program, we use some of our images $8, that they're bicultural, bilingual, other type of things, and also to fill hard to serve and hard to retain areas within LA County. But we've also added that criteria as part of the loan assumption programs and those, but that's on the more of a professional clinical level. The other thing that we really do feel that's necessary, I'm just talking about within our system, the use of peers and parents, and even defining and broadening the definition of a peer. Under MHSA, we define peers as a person with lived experience with a mental illness. We're finding in this presentation today, it fits perfectly into where we're going on things. You also have to have peers who are from a specific cultural community or group. They're needed as well. We've started looking at the use of the promotoras model and trying to expand that and adapt that to other cultural communities. But also, once again, it's not just so mental health focused. And unfortunately, our funding is that way. So we have to try to collaborate and engage other resources in the community that needs our help. So for example, a good example is when we take a look at one of our outcome measures for the full service partnership program has to do with employment, okay? Well, do you think, I shouldn't say it, I was gonna go in a different direction, I wanna go there. Yes, of course, treatment and those type of things will eliminate any mental health barrier that a person may have in terms of gaining employment, right? Or maintaining employment, but that person needs a job, right?
That's right.
There's other things that have to happen in this community. And part of our stakeholder process, everyone probably went through the 3-year planning process. This was the first year that we heard a lot about, you know what, let's go a little bit further upstream, right? Mm-hmm. Let's take a look at things in terms of what's causing folks to come into our system, right? Unfortunately, our dollars, even our prevention dollars, are very categorical because it has to be tied to a mental health issue. But those are other things that we need to really start to take a look at, because we can get someone job ready or eliminate their mental health barriers to employment, but if that person doesn't have a job, or if that person doesn't speak English that's required as part of that position, or isn't trained or educated, the mental health system can't deal with that or can't really help that person. So a lot of the stuff that we're doing, we're really thinking beyond just our traditional services and who provides them. It's also bringing in other community level type of things. We're finding out that a lot of our assumptions going into our integrated service management model, which will be discussed today, a lot of stuff that we just simply applied to that program don't work. There's engagement, yes, but there's no handoff. There should be no handoff. A person that engaged someone coming into the system should be there, available to them, and be there when they leave our system. And that community needs to have the capacity to retain that person in their community and support them, right? So all these different types of things. Now, coming from a bureaucratic perspective, I have to tell my staff that we're in a partnership here. We're learning. This is none of this audit and you're not meeting the qualifications or you're not adhering to the contract. This is a partnership. And that's where I think people have to really start taking a look at when you deal with the county bureaucracy. I shouldn't say, yeah, okay, that's right. But more than that, you're dealing not only with the bureaucracy, but you're also dealing with mental health folks who are also beginning to adapt and change. And that hasn't happened yet. Come on, folks, there's still a lot of stigma within our own profession. And we need to deal with that. And we also need to deal with the stigma within the community, because I think for the most part, what is limiting access to all of our communities has to do with stigma, right? But also, when we take a look at it, and this is a discussion that we had with the API group, take a look at what gets funded, right? In terms of, at least the API community, a lot of things that have high priority in terms of funding, there's not a huge representation of API in those groups. And the other thing, too, when they had the discussions about African Americans, and you compare that to these prevalence rates that we have, they're overrepresented. Well, you know what? You take a look at that. My question is, there's something wrong with that prevalence rate, and you have to then take a look at the diversity within that community. Africans, Ethiopians, Somalians, all those issues, those are emerging communities that need to have their chance in terms of access to services, but we're really far behind in developing those resources to serve them. But we're going to move on it. We're going to try.
Go ahead.
I think there's one thing to consider when you start looking at stakeholder process. If you're not funding African American specific providers, they're not at the table making the decisions for the stakeholder group. So lots of times when you come to certain communities, you only see the consumers and the family members. You do not see the service providers who carry the knowledge about how best to do it. And so I'm on this stage only because my name rose because we don't have a lot of mental health providers. And I focus on what's happening at the state, I lose traction of what's happening in my county. I focus on what's happening in the county too much, then they're making decisions to go forth with the cultural competency plans without having an African American voice. I ask, would you bake a cake, forget the sugar, and then come back later, sprinkle it on top, and think that cake is going to be something I want to eat? No. It doesn't matter what color the waiter or waitress is who's serving it, it's still missing something. So all of the communities need to work together to have a common voice around we are now the majority, and there shouldn't be decisions being made without inclusion from the people most affected by the decisions. And I applaud consumer and family members' voice, but lots of times they're not reflective of the other consumers who are most in need of having their voice rise to the top. The LE behind my name is lived experience because I'm a family member, so I'm very passionate about this work. And I know we can make a difference, but it's because privilege has to be moved out of the way. I can be at almost 6 feet tall, accepting a position as the shopper for people 5'2" and under. So people not from our ethnic community should not feel comfortable making decisions for people when they have no connection culturally or ethnically with what it's like for them from day to day. Most of the people making the decisions cannot even understand what it's like for an individual with a severe mental health challenge to navigate through a world that does put labels on them and do treat them badly. If that can resonate for you, you need to say, hey, wait a minute, let me go, as Jerry said earlier, let me go talk to Dr. Noble. He probably could actually, because he got soul in him. He probably could help a person from the African American community, because a lot of times it's not about, you know, you being exactly from that person's community. It's about you respecting that person and the fact that they want to make a connection with you that's non-judgmental, where you're not judging them and blaming them for where they are. And that's what we do a lot, especially with African Americans. There's a dehumanization of African Americans, and that's how someone as horrible as Zimmerman walked away from killing a young boy, because most people didn't see him as a young boy. And that's a sadness. And that's why I cry a lot too when I'm trying to do this kind of work, because I can't understand why we haven't moved to a place of being culturally humble about doing this work, and privilege prevails, and people want to make decisions without the tools to do it in a way that honors the people that would be affected by it.
Thank you, Gigi. Are there other panelists who'd like to sort of share any other reflections and in response to what's been said so far? And because I'm going to start wrapping it up. So.
Yeah, my only final thing as we close is that, you know, to me, this aspect of the way that we're approaching either the Mental Health Services Act or whatever, multiple processes that I can think of at the state level and even local levels where we engage in this remediation. Oh, we forgot people of color. This discussion is a remediation process. Mm-hmm. Okay, mm-hmm. We have CDRP mm-hmm. to study what our communities need. Many of us 5-6 years ago said we don't need to study, put the money out. And over the past 6 years, what's happened is that now the money is up for grabs. When that money was allotted and designated, it was very clear that it was going to be for communities of color. After 5 or 6 years, after the CRD reports, which I think are great, but at the same time, we don't need to continue to study what is happening in our communities. A lot of us already knew that. But what I'm getting at is that at multiple stages in the processes that we engage in, it's this remediation instead of really beginning, and I always like the statement that the network had, which is nothing about us without us. And I said, well, guess what? This happens a lot. You continue to have conversations about communities of color mm-hmm. without even talking to us, without even asking us. And there's a lot of examples of that. To me, that is the ultimate form of racism and discrimination. That you talk about what's wrong in our communities, don't ask us if really or truly that is a problem, or if we have a solution for it, or what we need for it. And people come in the same missionary mentality to fix what is perceived externally as a problem in our own community where it may not be. The other final thing is that I think our systems have to really address the issue that while in many other communities they're talking about improvement and the quality of care, we need to address the fact that for many of our communities, it's still very basic access. We haven't even gotten to a place where we can assess whether the quality of care is appropriate or what interventions or all of these things. We're still dealing with very basic linguistic access and just basic access and representation and programs and services that is on a voluntary basis because, the example of our institutions and forced care, we're certainly well represented in those. But as a walk-in on a voluntary basis, those are still our very basic challenges. And I want to make sure that we don't lose sight of that fact, because as we kind of move forward with all these interventions and strategies and programs and everything, the fact is that for many of our communities, they don't even know how to get into the door.
Yes. Yes.
And I'll quickly say that most individuals first turn to their faith communities when in crisis. So educating faith communities how to embrace individuals in a nurturing way without the stigma is one of the more important partnerships and collaborations we need to have. So we had a great conference here yesterday with Dr. Southard leading the way around building up relationships between the faith community and mental health, which was once married and, as he said, is in need of intense marital counseling. But because people turn there, we have to prepare them. So thank you, Doretha, for this opportunity.
Dennis, you want to make the last comment?
Very brief. I think one of the things that many folks are learning or have learned is that you can't define or judge a person by their appearance or how they look, or you can't define them by what they do or by their illness. So a lot of what we have learned through our lifetime, and not just because we're part of the mental health system, is the need for people to treat each other with respect and dignity. And that has to happen. Without that, I'm not saying that people can't disagree. You can oppose someone's opinion, but you know what? You have to respect them for having that opinion. You may not like it, but I think that's what we have to all agree on. I mean, there's a lot of things that are going on now that we see outside of the mental health field, but all of you have heard this, because we have so much damn money, they want us to spend it on all kinds of things. And believe me, being over image to say, you would not believe the requests that I get. But you know what? My heart goes out to them because somebody needs to address those issues. And if it's mental health, that maybe not fund it, but maybe if it's mental health and all of us as either professionals or community workers, why don't we at least initiate it and let's partner to do something about the larger community issues beyond just our own mental health issues?
Complex world. And here we are trying to marry something that really may not really be compatible with each other, right? A public mental health system that's designed a certain way with certain structures using a Western philosophy, a medical model with something spirit-led and indigenous to the roots and cultures of people who have been excluded from the process and sort of left out of the loop. I think we have a challenge ahead of us, but I have a whole lot of faith that we're all in this room for a reason, and that we have been in some way called to make this leap. And I think if we keep having these kind of conversations, that we're going to get somewhere. And you know what? I understand how difficult it is for you to do your work and to be at those tables consistently and to be the lone voice in the room and, the one when you speak, everything goes silent and nobody responds, or the one who's forgotten on the invitation list. And I just want to say thank you for keeping on, for keeping going, for staying in there, for not giving up, not walking away, and being willing to sacrifice yourselves and your families for us as a community. So thank you very much.